afternoon, respected teachers and my fellow batchmates. I am Deshna Jain, first year MBBS student, is here to represent a seminar along with my batch A2 on the topic fracture of neck of femur. Case: a patient named Sumita Sharma, a 78-year-old female with a medical history of hypertension and osteoporosis, presented to the emergency department with severe right hip pain following a fall at home. She trips on a loose rug and landing on her right side. She was unable to bear weight on her right leg after fall. Upon arrival, she appeared to be in significant pain. Her right leg was externally rotated and shortened compared to the left leg. There was tenderness over the right hip joint, and she was unable to move her leg without experiencing pain. On examination, the physician observed that the neurovascular bundle status of the affected limb was intact. Her vital signs were stable with no signs of hypertension or shock. X-ray imaging of the patient was done. An orthopedic surgeon interpreted a fracture in neck of right femur. Femur is a bone of thigh shaft. Neck of the femur or the femoral neck is a critical anatomical structure which connects the head of the femur to the this femoral neck the femoral neck fractures are very common injuries. They are more prevalent in older individuals due to they are prevalent in older individuals due to weakened bones, and they can also occur due to trauma such as car accident or sports injury. According to the studies of Koval and Zuckerman, the incidence of femoral neck fracture is 63.3 cases per lakh persons year for women and 27.7 cases per lakh person per year for men. Women have a higher incidence due to the higher prevalence of osteoporosis in women. So, we are here describing this topic into the following subtopics: the case, related anatomy, pathophysiology, investigation and anatomical basis of clinical presentation, management, and then summary. Next, for the anatomy, I would like to call my batchmate Harsh Chaudhary.
Good afternoon, respected teachers. So I'll proceed with the anatomy. So as we all know that femur is the strongest and longest bone in the body. Also, the femur can be divided into head, neck, shaft, and a bicondylar end. So the upper end of the femur has a head, neck, the greater trochanter, lesser trochanter, intertrochanteric line, the fovea, and the intertrochanteric crest. Also, the femur conducts body weight from hip joint to the tibia in standing position. Next, we'll know about the attachments of the femur. So, the upper end of the femur forms the hip joint, wherein the femoral head articulates with the acetabular cavity of the hip bone to form the hip joint. The acetabulum further presents the acetabular labrum, the lunate surface of acetabulum, and the acetabular notch. Uh, okay, so there are several ligaments which provide stability and strength to the hip joint, wherein the first ligament which we will see would be the fibrous capsule. So, as we can appreciate, the fibrous capsule, it is connected to the intertrochanteric line, and the fibrous capsule is divided into the outer longitudinal and the inner circular fibers, which are also called as the zona orbicularis. Next, we'll learn about the iliofemoral ligament, which is an inverted Y-shaped ligament or the ligament of Bigelow. Uh, this is a triangular inverted Y-shaped ligament, and it is one of the strongest ligaments of the body. The apex is connected to the anterior inferior inferior iliac spine, the lower half of the anterior inferior iliac spine, and the lower borders are connected to the intertrochanteric line. Next, we'll learn about the function of the iliofemoral ligament is that it prevents the trunk from falling backwards in a standing posture. Next, we'll learn about the pubofemoral ligament. The pubofemoral ligament covers the joint inferior-medially, and it is also a triangular shaped ligament. The apex is connected to the obturator crest, the obturator membrane, and the iliopubic eminence, and posteriorly it is connected to the capsule and the the lower band of the iliofemoral ligament. Next, we'll learn about the posterior view. The ischiofemoral ligament covers the joint posteriorly. The fibers are twisted and they extend from the ischium to the acetabulum. Also, some fibers extend till the greater trochanter, and as we can see, some of the fibers form the zona orbicularis. Next, we'll learn about the ligament of the head of the femur, which is also called as the ligamentum teres or the round ligament. So the apex is attached to the fovea capitis of the head of the femur, and the base is attached to the acetabular labrum and the transverse acetabular ligament. It transmits the arteries from the to the head of the femur, like the acetabular branch of the obturator and medial the obturator artery. Next, we'll cover the uh, Next, we'll learn about the acetabular labrum. So, the acetabular labrum narrows the lumen of the acetabulum so that the head of the femur fits accordingly and improves the grip of the head of the femur. Next is the transverse acetabular ligaments, which is responsible for the transmission of the various arteries, veins, and vessels to the head of the femur. Next, we'll learn about the important hip joint relations, wherein we'll see the anterior relations first. So we are able to appreciate the femoral nerve, the femoral artery, and the femoral vein. Also, the iliopsoas is separated from the joint by a bursa. Next, we'll see the posterior relations, the obturator externus, which is covered by the quadratus femoris. Also, the gluteus maximus is there, piriformis, and the tendon of obturator internus with the gamillae and the sciatic nerve. Superiorly, the joint is covered by some part of gluteus maximus, gluteus medius, and gluteus minimus, along with the tendon of rectus femoris. Uh, Inferiorly, we have pectineus, obturator nerve, adductor longus, gracilis, and the adductor brevis magnus and the hamstring muscles. Then there are seven types of movements related to the hip joint, which are flexion, extension, abduction, adduction, lateral rotation, medial rotation, and the circumduction. Circumduction is the combination of all the previous movements. So the flexion and the extension, they occur along the transverse axis. The abduction and adduction, they occur along the anterior posterior axis, and the lateral and the medial rotation, they occur along the vertical axis. So the major muscles which bring about flexion are the iliopsoas, rectus femoris, sartorius, and also helped by the adductor muscles. Then there is adduction, which is brought about by gluteus maximus and the hamstring muscles. Then we have abduction, which is brought about by the gluteus medius and minimus, also assisted by sartorius, tensor fascia lata, and piriformis. The adduction is brought about by adductor longus, brevis, and magnus, also assisted by sartorius. Then we have the lateral rotation brought about by piriformis, obturator internus, externus, the superior inferior gamillae, and also assisted by gluteus maximus. Then we have the medial rotation brought about by the anterior fibers of gluteus medius, gluteus minimus, and tensor fascia lata. And circumduction is the combination of all the previous movements. Thank you. I would like to Shruti will take over from now.
Good afternoon. I'm Shruti Goyal. I shall be explaining trabecular lines, nervous and arterial supply of the hip joint. So, trabeculi are connective and supportive tissues elements formed in cancellous bones. Trabecular growth pattern, usually seen under the X-rays, are formed due to stress and follow the course of stress lines along the bones. Maximum trabecular development occurs along these lines. Moving on to the arterial supply of the head of the femur, there are four major arteries supplying the neck region of the femur. These are the medial and lateral circumflex femoral arteries, the artery to the ligament of Treris, as well as the gluteal arteries. Now we'll look at the origin of these arteries. So first, we see the abdominal aorta divides into uh, left and right common iliac arteries. These arteries further divide into external and internal iliac. The external iliac continues as femoral artery. The femoral artery gives a branch, which is the profunda femoris artery. The profunda femoris artery near its origin gives two branches, which are the medial and lateral circumflex femoral arteries. The medial circumflex femoral artery is posteriorly forms a ring along with lateral circumflex artery, which follows an anterior course. This is known as the extracapsular ring. The extracapsular ring uh, rise to retinacular vessels. The retinacular vessels pierces the capsule of the joint and form three groups, which are the anterior group, the posterior superior group, and the posterior inferior group. The posterior superior group is main important for supply. Uh, these groups then form an intercapsular ring along the uh, joint articular cartilage. The articular cartilage, uh, the intercapsular ring further gives rise to epiphyseal arteries at the border of articular surface, and these form intraosseous anastomosis. Further, we look at the internal celiac iliac artery. The internal iliac artery gives rise to the gluteal arteries as well as the obturator artery. The obturator artery gives rise to the artery of ligament of Teres, which supplies a small portion over the head of the femur. The gluteal arteries, along with the branches uh, from circumflex femoral arteries, form the trochanteric as well as cruciate anastomosis. The trochanteric anastomosis is formed by the branch from superior gluteal artery, from inferior gluteal artery, the ascending branch from medial circumflex femoral artery, and the ascending branch from lateral circumflex femoral artery. The cruciate anastomosis takes place from the arteries of transverse branch of medial circumflex femoral artery, the transverse branch of lateral circumflex femoral artery, a branch from the inferior gluteal artery, and a branch from the ascending branch of first perforating artery, which is a branch of profunda femoris artery. Now we look at the blood supply. Now we look at the nervous supply. The nerve supply of the neck of femur comes mostly from the lumbosacral plexus. The four major nerves supplying are the femoral nerve via its branch to rectus femoris, the obturator nerve via its anterior division, the nerve to quadratus femoris, and the nerve superior gluteal nerve. Sciatic nerve is also related to the hip joint, but it does not gives any supply. Thank you. My classmate Kaustubh will continue.
Good afternoon. I'm Kaustubh Ganivewar. I will be presenting on pathophysiology at fracture of neck at femur. Pathophysiology deals with the abnormal changes which occurred before any diseases. The subtopics include etiology, clinical manifestations, and treatment. Out of which clinical manifestations and treatment are discussed later. Etiology. Uh, in our case, etiology deals with the factors which increases the risk of fracture. Due to aging, osteoporosis, due to metastasis of tumor cells into the bone, or due to homeostatic defect in homeostatic remodeling of the bone. Aging. It is the most important factor in old age, and in our case, aging may be the factor for the fracture. Aging affects the bone density, bone thickness, and bone porosity, and it decreases it and hence weakening the bone. Also, due to aging, osteoporosis occurs, during which the rate of bone reabsorption exceeds the rate of bone formation, and hence weakening the bone. Also, in old age, there may be some comorbid diseases such as hyperparathyroidism or hyperthyroidism, in which bone reabsorption increases and bone weakens. Also, postmenopausal, that is after 50 years of age, the levels of estrogen decreases. Estrogen, as we know, estrogen functions in mineralization of the bone, and if the level of estrogen decrease, then the bone would become weak. Also, sarcopenia. Sarcopenia, it is a disease. It is an old age disease in which muscle mass and bone mass decreases, and hence it causes weakening of the bone. Also, nutrition factors. In old age we need we need to provide more nutrition. For example, the calcium intake for adults is about 1,000 milligram per day, while in old age we need to give about 1,200 milligram per day. Also, protein deficiency, vitamin D deficiency increases the risk of fractures, and alcoholism and smokeism also increases the risk of fractures. As we can see in this graph, as we can see in this graph, here the as the age increases, the bone mass decreases. And also here, we can see that at the 50 years of age, there is sharp decrease in bone mass in case of females. Then metastasis of tumor cells. A secondary metastasis from any other primary tumor may get dislodged, may get attached to the bone and hence start a new tumor there. Then this new tumor inside of the bone, and hence in this process it replaces the bone tissue from with the tumor tissue, and hence decreasing the bone strength. It also may lead to hypercalcemia, and also if the bone tissue and if the tumor cells reaches the bone marrow, it decreases the blood cell count also. Defect in homeostatic remodeling of the cell of the bone. It occurs when the bone is subjected to repeated stress. It occurs in the individual which perform repeated weightlifting, running, or marching. And after the strenuous activity, enough time is not provided for the recovery. Its symptoms include bone pain, tenderness around the area, and structural fatigue. Uh, while the fractures can only occur in severe stages. This is uh, this is the process in which first, when a stress is applied, microfractures occurs. After which the osteoclastic activity increases, and the strength of bone further decreases. Osteoclasts dissolve the bone and decreases the bone cell content. The period of osteoclastic activity is of 1 to 2 weeks. After 1 to 2 weeks, the bone formation increases, and osteoblastic activity increases, which lead to formation of new bone. And after some of the osteoblastic activity, new bone is formed, which is more stronger and more thicker. If repeated stress is applied in the osteoclastic period, then it may lead to stress fractures. Other factors include increasing neck shaft angle beyond 135-degree, due to which there is increasing reaction force between femur and the hip joint, and also increase beyond 135-degree. Also, if there is increase in knee hip axis length, it causes increase in length of the neck, and as the neck is the most more thin part of the femur, it increases the risk of fractures. Next, I would like to call Prerna for continuing the topic.
Good afternoon, everyone. Myself Prerna Dave, and I am going to represent the classification of fracture of neck of femur. So, fracture of neck of femur is classified on different bases. So, first we will see the anatomical classification. So, anatomical classification is based on the different anatomical locations. So, these are of three types. The first one we will see the subcapital. Subcapital is the fracture at the base of the head, just below the head. Uh, and as we can see it in the figure, so this is the subcapital fracture. Then second is the transcervical fracture, the fracture in the middle of the neck. So this portion from here to here is the neck, and in the middle of the neck, the fracture that is called as the transcervical fracture. Then third is the basal fracture, a fracture at the base of the neck. So as you can see, this is the base of the neck, and when the fracture occurs at this level, it is called as basal fracture. The more proximally the fracture is located, the worse is the prognosis. So next we will see the Powell's classification on the angle of inclination of the fracture with relation to the horizontal plane, and it is of three types. So first, we can see in the type 1, the fracture, the fracture is making the angle 30° with the horizontal. In the second figure, type 2, we can see the fracture is making 50° angle with the horizontal. And in third type, we can see that fracture is making 70° angle with the horizontal line plane. So the more the angle, the more unstable the fracture is, and the worse the prognosis is. So next is the Gardens classification. So Gardens classification is based on the degree of displacement of the fracture, and it is mainly the medial rotational displacement. So change in the direction of the medial trochanter's trabecular steam. So these are of four types. First is the type 1 fracture, and it is incomplete and non-displaced. So here we can see the trabecular bending only, and it is making an obtuse angle. It is also called as the impacted or abducted fracture. Then in the second type 2 fracture, it is complete but undisplaced. The trabecula between head and neck and broken and displaced, as we can see in the figure. So the third type is it is complete and partially displaced. All the three sets of the trabecular are out of the alignment, as we can see in the figure. It is all are not in the alignment. In the type 4, it is complete and uh, fully displaced. The acetabular and the head of the trabecular in alignment between the head and neck and not aligned. So these two are in alignment, but these are not in alignment. So this is the Gardens classification. And thank you. I will like to call upon my colleague Abdullah Rabi for clinical correlations.
Hello everyone. I will be talking about the clinical features of fracture of femur neck. So if a patient comes with a fracture of femur neck, the leg will be externally rotated. There will be slight shortening of the leg and there will be tenderness in the groin. And if the patient attempts hip movements, they will be painful and associated with severe spasm. The active straight leg raising will not be possible, and the pain of the groin and or the hip area will be radiated to the knee because the obturator nerve supplies both the joints. The neck fracture is a emergency within 6 hours in the young patients, and in the older patients, it is an emergency and needs to be treated within 36 hours. The signs of intertrochanteric fracture and the fracture of neck of femur are same, so we should be able to differentiate between these two. The fracture of neck of femur, the tenderness is present in the Scarpa's triangle, that is the femoral triangle. Whereas in the intertrochanteric fracture, the tenderness, that is pain, is felt mainly at the greater trochanter of the femur. The fractured neck of femur it most probably occurs in the females, and the intertrochanteric fracture occurs mostly in the males. The external rotation is less than 45° in the fracture neck of femur. It is more than 45° in the intertrochanteric fracture. The shortening is very slight or less than 1 inch in the fracture neck of femur, and it is more than 1 inch in the intertrochanteric fracture. The fracture neck of femur are difficult to heal, and so their complication could be non-union. And the intertrochanteric fracture could they are easy to heal, but there could be malunion as a complication. So if the fracture neck of femur is undisplaced, there could be ambulatory. Ambulatory is the will be means that the patient will be able to walk and there will be minimal pain. This occurs in stress fractures. In displaced fractures, there will be external rotation deformity. There will be shortening of the leg, and the patient will not be able to ambulate. There will be ecchymosis. Ecchymosis means the area of the skin there will be changing color because there is bleeding underneath the skin. Then there will be restricted movements in the displaced fractures. The complications. The main complications occurs due to disruption of the retinacular vessels. The retinacular vessels are the vessels which run along the neck of femur, which will lead to avascular necrosis and further non fracture. And the more displaced the fracture is, and the more vertical the fracture is, the more likely the complications will occur. So now we are discussing about the blood supply, which gets disturbed or ruptured in the transcervical fractures. So the neck of femur is mainly supplied by the foveal vessels with the help of artery of ligament of teres and the retinacular vessels and the medullary vessels. The retinacular vessels and medullary vessels are more risk when there is fracture at neck of femur. So this surgical treatment for this is a head replacement or hemiarthroplasty. So this slide discuss about the blood relations of the femur. When there is fracture at the neck of femur, the main supply to the head of the femur will be from the artery of ligament of teres. The retinacular and medullary vessels will not be able to supply. So there is increased risk of degeneration of the head of femur. So the complications will be non-union because there is poor blood supply. So there will be more increased chances of the non-union of the fracture. It could also lead to avascular necrosis of the neck because the medullary blood supply is cut off from the teres. It could also lead to osteoarthritis. In the osteoarthritis, it is because of the avascular deformation of the head and union in faulty alignment. The fracture could be unnoticed if there is severe trauma of the severe trauma and more number of fractures at the femur. Therefore, it could be unnoticed, and we should to avoid this mistake, we should X-ray the pelvis so that we cannot unnotice the fracture. So from here on, Samant will talk about the investigation.
Good afternoon, respected teachers and my dear friends. Today I would be presenting before you the X-ray scanning and imaging of the femoral neck fracture. So generally during the femoral neck fracture, the radiography is the preferred imaging method. And if the fracture remains unnoticed, even in the CT scan, even in the X-ray, we can go for an MRI scan. We can also use nuclear medicine scintigraphy to assess the condition of the bone density and also to check for osteoporosis in the bone mass. So mostly during the X-ray imaging, we take an AP pelvis view. We may also go for a cross table lateral view if needed. The following diagram shows the image in which you can see sclerotic lesions at the site of the fracture. These are mostly due to the new growing bone at the site of the fracture. The sentence line is a continuous line. The sentence line is a continuous line and the inferior border of the superior ramus of the pubis. If the continuity of the line is broken, then we can suspect a femoral neck fracture, as we can see in this diagram. The following diagram shows a trabecular pattern. The trabecular lines inside the femur are mostly arranged into the compressive and the tensile groups, and they form a Wart's triangle. This is a triangular shaped triangle. If the Wart's triangle is enlarged and distorted, then we can suspect a femoral neck fracture. Also, we can see that the trabeculae are slightly accentuated and bended. This can be an indicative of femoral neck fracture. The next diagram shows a prominent lesser trochanter. This can be mostly seen due to the external rotation of the shaft of the femur. This diagram shows the Gardens classification for femoral neck fracture. In this classification, we can see that during the grade 3 and grade 4 fracture, it is pretty clearly visible inside the X-ray imaging. But the hairline fracture or occult fractures might often go unnoticed because they are very subtle on the X-ray. So during such cases, we may need to use the MRI scanning. So this is the image of MRI scanning. The MRI scanning can not only be used to assess the type of fracture, but we can also see if there is an abnormality in the surrounding joint, if some sort of infection has occurred around the joint, or if there is some torn cartilage or ruptured ligament. We can also directly measure the degree of displacement and we can predict the viability of the head of the femur. The MRI scan is very crucial in surgical planning and also to decide the choice of the surgery, whether we have to go for a hemiarthroplasty, whether we have to go for a complete hip replacement, open reduction, closed reduction, sliding hip screw. All of these needs a detailed and thorough MRI scan. After the MRI scan, we can see the given in the long axis and short axis view. In the ultrasound, if we find a presence of hypoechoic fluid accumulation, this can be an indicative of an intratrochanter intra-articular hemiarthrosis or a joint diffusion or something like an iliopsoas hematoma. The ultrasound can also be used to give a guided femoral nerve block. This is mostly used in pain management in the emergency room and also for the surgery of the femoral neck fractures. This provides a pinpoint regional anesthesia to the femoral nerve, obturator nerve, and the lateral cutaneous nerve. This is an image of the duplex scanning or the Doppler ultrasound. This technique mostly uses the sound waves and Doppler's effect to assess the condition of the greater vessels. This also can measure the blood flow through them, and we can detect the stenotic blood vessels and the collapsed or ruptured blood vessels. This method is also used to plan the risk assessment for deep vein thrombosis, because the risk of venous thromboembolic diseases is greatly increased if the time of presentation or the subsequent surgery in case of femoral neck fractures is delayed. In this figure, if you can see figure number 8, it shows a hypoechoic artery with turbulent flow through the diameter of the vessel. And in the figure C, we can see a pseudoaneurysm in the lateral circumflex artery, which is a branch of deep femoral artery. Now I would call upon my friend Swati to present with the management of this case.
Good afternoon, myself Swati Giri. I'm going to present on management of femur fracture, head fracture. So, treatment scheme. So, the first technique of treatment is conservative one, and it is basically done in children's and exception with some exceptions in elderly people. The next one is surgical one, which can be further divided into joint replacement. So basically, osteosynthesis has three procedures under it. So the first one is closed reduction and cannulated screw fixation. Second one is open reduction and cannulated screw fixation. Third one is compression hip screw with plate fixation. So basically, in closed reduction cannulated screw fixation, we make an incision 3 centimeter distal to the greater trochanter. So basically, there are three screws. The first screw is placed at the inferior aspect of the um, neck of the femur. The second one is placed posteriorly, and the third one is placed anteriorly. So, open reduction and cannulated screw fixation. This technique is basically used when the closed reduction technique fails and when there is a neglected fracture. Now, compression hip screw with plate fixation. So basically, it works by applying compression at the fracture site. It permits controlled collapse, leading to increase in bony contact. Therefore, it provides extra stability, and there is constant decrease in stress on the plate. Now, hemiarthroplasty. So there are two procedures under hemiarthroplasty: Austin Moore prosthesis and Thompson prosthesis. Basically, Austin Moore prosthesis and Thompson prosthesis are similar. Indications in both are non-union, and it is used for the age group greater than 60 years. And there is femoral calcar in both. But in case of Thompson prosthesis, there is inadequate femoral calcar, there is pathological fracture, and there is osteoporosis. Now, total hip arthroplasty. The indications are pre-existing acetabular disease, displaced fracture in old age, and it is done basically in age group greater than 60 years. So, in total hip arthroplasty, there is an additional acetabular component as compared to hemiarthroplasty. Thank you, and I would like to call upon Aarti for summary.
So the summary is a focus on the neck of the femur fractures. So we began with the introduction. It is the providing an overview of the neck of the femur fracture. Providing the neck of the femur fracture and its impacts on the patient's lives, as we saw in the slide. As we saw in the slide, we see the slide fracture of the neck of the femur, and the lady is came at the leg is the externally rotated, and patella is the facing patella is the facing outward. Then we delved with the anatomy of the neck of the femur, explaining the explaining the very complex structures and the type of the fractures that can be occur. As we see in the slides, there is the anatomical classification, Paul's classification, and the Gardner's classification. This section is aimed to emphasize the fractures pattern and the associated complications. Then we saw the pathophysiology and causes of the fracture. And we highlighted the vulnerability of the neck of the femur fractures that can cause due to the loss of the blood flow, osteoporosis, and the traumatic injury causes. We aim to emphasize the emphasize the need for the preservative measures and the early interventions. Then we show the clinical presentations of the neck of the femur fractures, such as the typical signs and symptoms, deformity, limitations of the motions, and additionally we can give the information through the medical history. Then we saw we use the X-ray imaging for the diagnosis and the classifications of the neck of the femur fracture. As we saw in the X-rays, right, there is the point on the neck of the femur fractures. Then we goes with the we address the finally managements of the neck of the femur fractures, as we discuss about the surgical and the non-surgical aspect, taking an account to according to the age, sex, and deformity. We discuss about the management of the neck of the femur fractures. Then in conclusion, the seminar is provided. In conclusion, the seminar is the provided the comprehensive overview of the fractures of the neck of the femur. It covered the aspect of the pathophysiology, anatomy, clinical presentation, and understanding imaging and the management. By increasing the participant, the understanding information of this topic, we improve the patient care and outcome of the management of such challenging fractures. So this is all about from our side. Thank you.
पंपी मैडम प्रेजेंटेशन इज डन। आपका आवाज बहुत लो है पंपी मैडम। So again, once again, congratulations to the team. Very nice presentation, very educative. Those students who have attended, I think, must have been enriched. And of course, the students who prepared it, congratulations to them. Very detailed study, and congratulations to your batch teacher, Pampi madam, for guiding you so well in this presentation. Thank you so much. पम्पी, आपका आवाज बहुत कम है, आपको माइक पास में देना पड़ेगा।
I'm so sorry, sir. I can't use my.
हाँ, अभी सुनाई आ रहा है, बोलो।
Sir, thank you, sir, for giving us the opportunity to talk on this topic. Thank you, Shasjo sir, our HOD, and Bose sir for constantly guiding us. And because this is an opportunity for the student to learn more than the knowledge. They have learned how to work in a group. So they showed it like from the last 3 days they are preparing there, and today they have did well. Congratulations on
Shyam Kishore sir, would you like to say something? हे सगळ्यांनी पटापट आपली नावं सांगा. एक तर ही पोरगी समोरची मला माहित आहे, आरती. अजून बाकी लोग नाम बताओ. ब्लर्ड आ रहे आप लोग सब, भाई सब कैमरा ऐसा एडजस्ट किया है कि बाकी बैकग्राउंड ब्लर्ड आए. आरती के बाद श्रुति, श्रुति के बाजू में और समर्थ, और ये लड़का बीच में हाथ डाल रहा है, वो कौन है? नाम क्या है उसका? अनम्यूट करो अपने आप को, यू आर ऑन म्यूट, अनम्यूट करो. हाँ, अपने अपने नाम बोलो.
Myself, Harsh Chaudhary.
हर्ष चौधरी, श्रुति गोयल, उसके स्वाति,
स्वाति जी.
स्वाति गोयल, हाँ. प्रेरणा, प्रेरणा, वेरी नाइस. प्रेरणा, स्वाति, वेरी नाइस.
देशना जय.
फ्रॉम जैन हॉस्टल. इसके बाजू में कौन है लड़का? नाव ऐकायला नाही आलं.
Abdullah.
अब्दुल्ला.
Kaustubh Ganeriwal.
कौस्तुभ.
And I am Samar.
You are Samar. You are not seen. अजून वाट खाली जरासा. Very nice, very nice. And I hope all of you also must have enjoyed. So can anyone, two of you, would like to share your experiences, what you had during making of this seminar and how you are feeling now at the end of the seminar?
देशना बोल.
कैसा लगा देशना?
It was very nice for presenting the seminar. We have studied and prepared the slides, so it was a learning experience. And we also learned how to present the seminar in front of our
Yeah,
and
because
also
सेकेंड ईयर में जाके आपको ऐसे बहुत सारे केस प्रेजेंटेशंस करना पड़ता है. तो you have now added advantage that first year only you have done a seminar. Very good.
They are having party at Swati Kiri's flat.
किधर पार्टी किधर है?
अभी स्वाति के घर पे ये लोग सब लोग उसके फ्लैट पे. करेक्ट ना स्वाति?
स्वाति लोकेशन भेज मैं आ रहा हूँ.
So they are just staying, for the seminar they are staying at the flat which is near to
एंजॉय द पार्टी की फोटोज भेजो मुझे. बाय बाय. वेरी नाइस. हैव अ नाइस वीकेंड. कल से पढ़ाई चालू करो आपका एब्डोमेन का. ओके, एंड वेरी नाइस. एंड वी फेल्ट नाइस दैट ऑल ऑफ यू पार्टिसिपेटेड. अदरवाइज जब हम वॉलंटरी लगते हैं और थोड़े ही बच्चे पार्टिसिपेट करते हैं तो अच्छा नहीं लगता. रिकॉर्डिंग किया है आपने?
yes sir.
आपको अगर चाहिए कि मेरे चैनल पे अपलोड हो तो मेरा ईमेल आईडी मैंने ग्रुप पे डाला है, वहाँ पे डाल सकते हैं. या आपके कहीं तो उसको अपलोड करना है आपको आपके इस पे अपलोड करना है, करो. लेकिन लिंक हमारे साथ शेयर करो तो हमारे बाकी के स्टाफ मेंबर्स देखेंगे और हम बाकी स्टूडेंट्स को भी देंगे देखने को. ओके, दोनों जगह करना है आपको. आपके यहाँ पे करना है, हम मेरे यहाँ पे भी करना है तो भी पॉसिबल है. नो फोर्स, नथिंग. आपको अगर इच्छा है कि मेरे चैनल पे करो तो मैं आपका प्रेजेंटेशन अपलोड करूँ. आपने स्क्रीन रिकॉर्डिंग किया है या प्रेजेंटेशन सीधा?
सर दोनों के.
दोनों. ओके, thank you so much and congratulations again. Excellent presentation, excellent. And I'm definitely sure that you also must have enjoyed it. Okay.
Thank you sir.
Thank you sir.
And thank you students. Well done students. Bye bye.
Bye, ma'am.
Bye.
Bye.